ask you something. If you ever had a nurse come into your home to care for your loved one, when they walked through the door with their bags and their paperwork, did you ever wonder how much of their time was actually spent with your loved one and how much of it was spent on their laptops writing out all of their notes? But the truth is, the nurses and the home healthcare clinicians who care for our loved ones are swimming in paperwork, documentation, compliance forms, billing codes, assessments. I recently had the pleasure of being a guest on my guest podcast, and the conversation we had there made me want to bring him here. Arvind Sarin is the founder and CEO of Copper Digital, a company at the forefront of AI-powered automation for home healthcare. He has spent more than 15 years building technology that solves real operational problems, and he has pivoted his entire company toward one mission, giving clinicians their time back so they can give more of themselves to their patients. Hi, my name is Jeanette Yates, and I'm the founder of The Self-Caregiver. I cared for my own mom for several decades, and now I help caregivers set boundaries and use simple tools that make care and life easier so they can feel good, not guilty. I recently had the pleasure of being a guest on my guest podcast, and the conversation we had there made me want to bring him here because what he is building matters to every family that has ever had an in-home health nurse walk through their door. Arvind Sarin is the founder and CEO of Copper Digital, a company at the forefront of AI-powered automation for home healthcare. He has spent more than 15 years building technology that solves real operational problems, and he has pivoted his entire company toward one mission, giving clinicians their time back so they can give more of themselves to their patients. He also is the host of Inside Home Health podcast, which I had the pleasure of joining, and a genuinely thoughtful voice on where healthcare is going. Arvind, welcome to the podcast.
Well, thank you, Jeanette. That was wonderful. I really appreciate that. And hello to all of your audience. Really excited to get in this conversation.
Yes, I had so much fun talking to you, and we brought up a lot of important topics in your podcast, which made me want to bring you on here so that we could talk about some of those similar things from a different perspective than we usually get here on the From Guilt to Good podcast. So I always open by asking my guests about their personal connection to caregiving, and I know yours comes from a different place than most of the people who sit across from me, but I think it's just as real. Your connection to caregiving comes through the clinicians your technology serves. Tell me what you've seen and what made the problem of administrative overload feel so personal to you.
Absolutely. Well, thank you again. So for me, it was really important to solve a problem that's not just for our own benefit or for the benefit of just a small group and for some monetary gain. And what I found was that the technology over decades has been going to the hospitals because they have the bigger budgets. However, when you look at the home health and the clinicians, they've always sort of been this second-class citizen in a way that all the dollars are going for ambient scribe for the doctors, which we know that's been around for decades now, but none of those types of technological innovations made it through to the clinicians. And the result of that was very visible. I looked at some of the numbers, and of course, it was a little bit of my business hat and trying to understand where we could have the biggest impact. And what I found was that clinicians are really struggling, not just because of documentation, but also because of such a high demand, because of our aging population, because of the reduced reimbursements. It just felt like multiple market forces were sort of pointing me to this direction, to this problem. So very early on, I understood that this is the area where we want to do something. But just like many problems, when you just start to get in, you don't know where to begin. And I mean, I saw that initially, I thought, okay, missed visits is a huge problem. And, patients not being available is a huge problem. And then what I did was in my office, I put sticky notes of every single problem that I could find. I had multiple research agents and of course reviewing it myself as well, looking at the reviews and looking at the feedback and forums. Anywhere where I could see that the clinicians were communicating, I would go and try to understand, okay, what are some of the problems? And then once I saw a lot of those problems, I realized that this documentation was really, really the biggest challenge because, of course, nurses didn't go to school to do documentation. It's more for caring for the patients, for really developing that connection and having all of their cognitive load focused on having that one-on-one conversation and comforting the patient, and then over to the next patient. But where's the time for documentation?
Yeah. Well, and there doesn't seem to be any kind of acknowledgement of that when it's all about like how many patients can we see in one day and get to and all that kind of stuff. And then, but we still need the documentation because that's how the next nurse knows what to do and how to start and all that kind of stuff. So it is a slippery, slippery slope there. But one of the things that I found when I was doing some research for this episode is that you actually founded Copper Digital alongside your late brother. And I can imagine that the mission of the company carries a particular weight for you personally. Would you be willing to share a little bit about that?
Absolutely, yes. And, of course, it makes me emotional. So my younger brother, I used to say that he's the smartest one in the family. He went to IIT Madras, which is like the MIT of India. And he was the first one to go to such a great college. And, then I had come here to get my master's in electrical engineering and then got my MBA. But after that, I asked him to join me in this startup, which initially the idea was the boom was about mobile. So we started with mobile, then transitioned to cloud transformation and then digital transformation. And we had many different domains where we would do projects. And really, we had our own struggles. He was struggling with addiction. And then, one fine day, I was not around and I got a call from my dad that he had passed away. And that was just a really, really, a big shock and like life-changing experience for me. I took the next flight from Norway and came back to Dallas. But then that period just gave me an opportunity to reflect and see like a bigger sort of purpose for what I wanted to spend the rest of my life doing. Because, he was the closest to me and he could just go away like that, made me realize that everyone's going to go away. So how do we use our remaining life to help others and to spend time with the loved ones? And while I was thinking about that, I did some meditation, went for Vipassana 10 days. And then what I realized was that I got to double down on this idea of helping clinicians and specifically starting with home health, because whenever you're setting a big goal, that's going to take a long time. And the more narrow you could keep it, better it is from sort of the business standpoint as well. So he's always there. I think about him, many times every day. And he was the CTO of the company, but now I'm having to, of course, work with some other folks and then learn a lot of the tech stuff as well. But yeah, he's definitely the one who's fueling the mission and giving me that resilience to continue to go on and have a huge impact. And eventually, all the clinicians should be like in love with this product where it makes their lives easier, not just for documentation, but eventually teach back, teaching the caregivers, teaching the patients as well about the disease process, about the medication, reducing the rehospitalization, reducing the fall risk. All those things have become like such a core part of my mission now. And yeah, it's exciting.
Well, thank you so much for sharing that. I know whenever we kind of get into the personal side of things, it's hard, but I do think it's important for us to, especially in cases like yours, very similar to what I have gone through since the loss of my mother. It's really helped me to focus on, okay, what am I going to be doing now for the rest of my life, and how can I fulfill that bigger purpose of my life and leave a legacy that she would be proud of, that I'm proud of, and that honors my family. Thank you for sharing that aspect. And you talked a little bit about the business side of why you chose the specific area. And maybe this is part of what you just shared, but is there a moment that you realized the home health industry was where you needed to focus? I know you kind of talked about from the business side of things, but was there another moment, or maybe even after you started working with the home health, where you saw the fruits of your labor? Can you talk a little bit more about that?
Like our main business was helping with digital transformation. So customers like Westinghouse or Mount Sinai, Texas Health Resources, they would come to us with a very specific problem that, hey, we want to develop this prototype or this app, or we want to launch this workflow. So it could be some sort of automation and all. So just like this, there was this discussion that I was having with, somebody in home health, and they told me about some of the problems, and then I was like, oh, that sounds interesting, and this is, seems like a big enough problem. But then that was many months ago. I still needed to understand and empathize with all of the different stakeholders within that space as well. But I mean, I think the reasons, like I described, were the compliance pressures, the reduced reimbursements, and the crackdown on a lot of the fraud. And even though it is cracked down on fraud, but a lot of, most people are just, even if they're making mistakes, those are honest mistakes, and there should be a good process for that. So that compliance is one market force. Then, of course, the reduced reimbursements, that just really pushes home health agencies to find new ways of running their operations more efficiently so they could have, at least a little bit of that margin to continue to go on and expand and grow. And I think there's another reason too, like this is a very fragmented market, and there's 11,500 Medicare certified agencies in the US. 1,900 of them are right here in my home state of Texas, and then Florida, California have a lot of them as well. So I felt like it's not that the entire market would get the technology like very easily. So we'd have to go and work with a lot of smaller agencies and then slowly sort of grow. And that's good in a way because that helps you sort of learn from your experiences and go to the next one and have an improved product. But the point being, like, it's going to be very difficult for this one market leader to, be able to capture everything quickly. So I was like, there is a need here because, there's going to be agencies in different states and different sizes.
And different compliance issue, like different compliances in each, area. There's all this different kind of stuff. It reminds me of when I used to teach in the public school system. There's constantly, you're like, I just want to teach the kids how to read. Like, why am I having to do all this other stuff? But it's just part of how it is. And then anything that can help the nurses or the clinicians, just like anything that can help the teachers get back to teaching, anything that can help the clinicians get back to actually doing what they were trained to do is wonderful. We're talking a lot about the business side of things and the clinician side of things, which is one of the reasons I actually really thought your voice would be valuable for my audience, even though it's mostly caregivers, because I want my listeners to understand what is happening behind the scenes, because most of us, we're in the middle of caregiving, we're focused on our loved one, and we don't really see what the nurse is dealing with, what happens when she leaves the room. And honestly, some of us may not care necessarily because we're also dealing with a ton of stuff that's not. And so I want us to really humanize that picture for everybody. Speaking of pictures, I want you to paint me a picture of a home health nurse's day. How much of it is actually spent on patient care and how much of it is usually spent on documentation and administrative work? Let's talk about that a little.
Yeah, no, that's a very important question. And I'll tell you this, I'm telling you from my recent experience. So I'm right now also at a customer location because I like to just be there in their office where nurses are coming in to pick up the supplies and going to the next patient. And they can be like, oh, by the way, we did this note in AI and it was great. Or there were these challenges. So I like to be here. So I'm spending not a Copper Digital office. On Tuesday, Wednesday, and Thursday, I'm here at the customer location, and they're great. It's very important, for anyone interested in understanding sort of the business side of it, to find your first few customers that are really transparent and open and encouraging, because there's going to be challenges. We're taking on a huge mission. There are so many visits that happen, and it's really important. So for a day in life for a clinician is like, it starts really the night before. So she would take a look at, okay, tomorrow, how many visits do I have? And different nurses get paid differently, but a very common way is that they get paid for every visit. There may be like a base component or something, but they get paid per visit. So then they would start by looking at their schedule for the next day by going in the EMR. And, usually that schedule gets finalized like for the entire week on the Friday before. So then they kind of have an idea. And most nurses would have on average like about 7 visits a day. That could be anywhere from 5 to 10 visits per day. And the way that it works is like the clinician probably starts the day very, very early and then starts, like to avoid the traffic and go to the patient's home. But then the clinician's first calling the patient and making sure that, hey, Mr. Smith, I'm going to be coming in tomorrow between 10 and 12. So there's always this window of time that's given because it's very hard to like meet a specific time with how long would the previous patient take, or could there be some other challenges that you could encounter. So there's usually like a 2 hour window. And then the clinician is gonna make sure that she's got all the supplies. If she needs to go to the home office, then come in here and get the supplies. And then the clinician would drive to the first patient and do the head to toe assessment. And then she would sort of figure out this schedule with that particular patient for the rest of the 8 week period, whatever authorizations have been received, like the 60-day period. So then she'd be like, okay, well, I'm going to be, depending on if it's once a week or twice a week, she would be like, okay, I'm going to be coming in on Tuesdays and Thursdays to you, in the afternoon. Mr. Smith, would that be okay? So she'd have that conversation. So then once she finishes her first visit, then she's going to go back to the car and make sure that, okay, she got the paperwork signed, because there's the paperwork, like you have to identify with 2 identifications and be like, okay, yes, that's done. And then, at times she may have, like this agency who's our customer, they give iPads to all the nurses. So then she would maybe feed the vitals in that and the start time and the end time, because those are important things. And, you could forget those. And then she may have some other notes about what interventions she did and the goals of the patient and all of that stuff. Now, before then, she also has to review the entire chart, because guess what? She's seeing maybe 40 patients over a week. So she has to sort of remember that, okay, this is a patient with, hemiplegia and, CVD. And these are the goals that I set out for myself. So this is what I have to do. This is what I have to teach. So once that is done, she would come back to the car, just get a little bit organized, put in the directions for the next patient, then go to the next patient, rinse, repeat, and then go to the next patient. And while she's going there, some of the nurses show me that they have a ream of papers, okay, that they're taking notes, or they have a diary. I mean, even though they want to be very technology centric, and yes, they have iPad, but then she's like, I want to care for the patient. I don't want to be like patient to be thinking that, oh, why are you going on the side and typing notes and stuff?
That's what I was going to say too, that like a lot of times, so in addition to like knowing all of the stuff you need to know for the actual care of the patient, it's also like they live with their daughter and their daughter's name is this, there's a cat there, and or what, like there's also all of these other incidental things that they're having to remember. And then also the consideration of the way that everything they do communicates something with the person that they're caring for. So even if they know I'm on my iPad for work, maybe it bothers their patient or it bothers the loved one, or it can look not great, like it can look not professional to some people. And so that all has to be taken under consideration. And of course, we've all been there where we've taken the iPad out or the laptop, and it hasn't been charged enough, or we can't get the Wi-Fi, or like there's all that. So with paper, you at least know I can just write this down and deal with all that later. And once I get in my car, or once I get home at night or whatever.
Absolutely. So then, as somewhere along the day, then would come lunchtime, which, she may pick up a Subway or a salad, or she may have some meals prepared. She's going to eat in the car, or maybe go to a Starbucks. And at that time, she might think that, okay, you know what? I have patients from yesterday that I couldn't do last night. Let me see if I could do some of them. And then she might be able to finish maybe 1 or 2, but then continue carrying the rest of the backlog, go to the next patient, then the next patient, and then end the day, maybe around 6:30 or so. And then when she ends the day, she goes home. And that's when, because I asked this question when I was doing nurse training, how many of you last week were charting at 7 p.m.? I mean, it seemed like everybody raised their hand. And then I was like, okay, well, let me ask you, how many of you were charting at 9 p.m.? I still saw a lot of the hands. And then my next question was, how many of you were charting over the weekend? And yes, a lot of them were, because guess what? If you don't have your paperwork in and your timesheet and everything, then your paycheck, is going to be short, because you got to turn in, those notes or at least the timesheets by the weekend, so that, the HR is able to pull that in. And like I said, they get paid per visit. So it's extremely important.
Yeah. Well, so, and this is making, as you're talking, like, I know I'm starting to get like a panic, I'm starting to get anxiety, and it makes me think about, the burnout that we experience as caregivers is probably also happening to the clinicians that are coming in to help care for our loved ones as well. Everything that you just described sounds like a recipe for burnout. And, while I do care for the burnout of the clinicians, one of the things that I want to talk about is how that burnout then affects their ability to care for our loved ones. So those of us who rely on home health to help us not be so burnt out, what does that clinician burnout ultimately mean for the quality of care that a clinician is giving to our loved ones?
Absolutely. Imagine the stress that, oh, not only was my paycheck short, but I'm getting all these calls from my teammates, from billing, from intake, from the director of nursing, asking that, hey, your notes are still pending from last month. And again, in all fairness, they can't send the bill unless the notes are in. In fact, if there was a physical therapy that was happening on the site as well, the entire bill needs to have all the notes. I mean, so even if the one note is missing for that entire period, you cannot send the bill. And then, of course, if you don't do that, then the reimbursement's going to be delayed. And then, of course, managing the cash flow. So it's not unfair for the office to call and check on the notes, because when I talk to them, they're like, you know what, this is the hardest thing for us to do, because I know, Sandra was taking 10 visits each day, and she's the one who does most visits. But yeah, I mean, it's hard, but there's no way that you can help, because only the nurse knows, only the clinician knows what she did and what to chart there. I mean, so pretty much she has to do it. Like, no one else can do it for her. She has to do it.
And obviously that's going to weigh on them. And as all of us who are burned out as caregivers, we know how that affects our ability to care for our loved one. The same thing is going to end up happening. And what it sounds like to me, though, is a lot of the clinicians, when given a choice of providing good care to the loved one or filling out their paperwork, most of them are giving the care and then dealing with the paperwork later. And of course, that just causes a snowball of issues. And you also mentioned something that I had totally forgotten about when my mom was still at home and receiving some care. She had one company, and that company sent out a nurse, physical therapist, and an occupational therapist. And what you're telling me is everybody had to have their notes in, even though it's three different people. They came on different days at different times. They all had to get their notes in order for the billing to be able to be processed and done. And so that causes a whole bunch of issues. So this is all just, this speaks to the whole system and how we're all grasping for tools that help. And then to your point, like something that you're addressing that not many tech companies is that home health care, the use of AI technologies in home health care versus, like you said, in facilities or in healthcare systems and all that kind of stuff. So as we're talking about the use of AI in this documentation space, let's break it down for people, because I think you and I talked about this on your podcast as well. We have this like love hate, this is cool, this is scary feeling when it comes to AI. So I know a lot of my audience is still trying to figure all that out. We hear the term AI, we wonder what it is. And we also think, is this going to replace the care my loved one is receiving? Is it going to make care feel less human? So we're going to talk about this directly. So what does, especially in the case of how your tools are being used, what does AI actually do in the home health setting? Make it as plain as you can for us. And what does it not do? So what is it doing? What is it not doing?
Love it. Okay, great. Well, thank you for that question, because that is the central question, and that's a very important question. Of course, I mean, I see that as well. Many people are just, oh my God, look at what AI can do for me, and this is how I'm using it. And many others are like very skeptical, and they're like, oh, it doesn't do this. And, nowhere close to the important work that I have. Don't be having AI touch, any of that. And I think because of that, it just becomes very important to understand in what ways AI currently can help. And so I'll give you our example and I'll try to make it very, very simple. So imagine this. We're just asking the clinicians, whatever you did during the visit, go ahead and record a note as if you're talking to a colleague, a supervisor, and explain what you did and what you noticed. That's it. It's a 2-minute, 5-minute, 7-minute recording where you're just going to give a narrative of what you did. And then, so that's essentially what it is. Just put a recording in our portal, and what AI does is takes that and has the context of all the previous visits and the conditions, the primary diagnosis, the comorbidities, the functional abilities of the patient. So it marries it with the narrative and says, okay, well, I understand what you did. And it fills out all of the documentation for that skilled nursing visit. And what that means, what they want is, okay, well, if the vitals are within normal limits, then good. If there was a challenge with cardiovascular, then you want to mention that and give us the status. Is there any pain that the patient's having? What about incontinence? And so there are all these different bodily systems that they have to do the assessment on. And not a whole lot's going to maybe change, or if it hasn't changed, then you just don't mention it. You just tell us what's changed, what did you do? And the clinicians are often like, oh, I arrived at the home and the caregiver opened the door. The patient was sitting in a recliner. Then the patient was looking just fine. There was no pain, no new falls, no infections. And then I asked about, the incontinence and this and that. So, whatever it is that she did, in a quick summary, she gives it, AI fills it, and puts it in the EMR. Now, before then, there is one step. Electronic medical records. So it's the system where all of the patient's information is stored and all the visits are there. And when the surveyors come in, that's what you would open up and say, okay, look, we've been following the process and doing everything as required based on the conditions of participation from Medicare. So what I'm saying is 4 steps, if you could imagine. Nurse records the note and AI extracts it and writes the entire note. And then a human checks it and your EMR has it. So that's it, these 4 simple steps. Now, obviously, we're not going to stop here. There are more things that we're doing. So there's one of the essential parts of home health is teaching the patient and the caregiver about the disease process, about the medications. And what we're trying to do is come up with those common teachings and put it in a nice video that's the best suited for patients, elderly patients, so they can just say, okay, well, that's what this medicine does. That's what blood thinners are for. And this is what the precautions I need to take, or what do I do if I fall? So we've created all of these videos. Again, that's an add-on and another idea.
Okay, so you just described what especially your tool is already doing. I love how you mentioned that even after the clinician talks about what happened in the visit, it is transcribed and recorded into the electronic medical record. It is human reviewed. I love how you keep the focus on making sure that there's a human involved in all of this from the get-go. And, one of the other assumptions I think that a lot of people have, especially those not like you and I that are steeped in all of this stuff all the time, but that this is something that's coming down the road, like AI is going to, be more involved in everything. But in the healthcare setting, especially, AI is something that is being used already quite frequently. We've talked about some of the ways it's already being used, but what is also coming? So what is down the road? What is on the horizon? And especially, what are some of the things that you're working on?
Absolutely. Now, that's the beauty of any transformative technology, that it seems like, wow, look at the possibilities, what we can do. Like back in 60s and 70s with the computers, everyone was going gung-ho, what's going to happen? And I watched those archive videos from BBC, and that's how I know. And some of those articles would tell you oh, look at what all these people were saying, that computers are going to change the world, but hey, we're still doing the same thing. Or in 90s when the internet was supposed to just change everything, oh, where is all this e-commerce that everyone was thinking is going to come? But the point is, look at it now. So given enough time, we're going to see all these things that we can imagine from a capability standpoint. However, everything needs to be rolled out in a very safe way. I'm a huge fan of the way Anthropic sort of has their manifesto about, safety first and everything. And what I feel like we're going to see in the coming decades is like everything that we can imagine. And of course, some specifics in caregiving would be like, imagine this. Right now, we have sometimes the HNP, which is like history and physical of the patient. So like from the referral packet, like if someone goes to the hospital, they come out, they come back with a big stack of papers. That paperwork needs to be reviewed by the clinician, and that could take a long time. And, some of the information is repetitive. But what if like we could give a visual summary, a quick summary of what's happening. And then, of course, if they want to go deeper, then they could look at the entire paperwork as well. Now, what about some people who are audio learners and somebody who's on the go from one patient to the other? Imagine being able to just get the summary of the referral. Now, not all visits are brand new admission. In fact, there are like 10 times as many regular visits that happen. And for those regular visits, we have already established a plan of care. So we know the goals, we know the interventions to be performed. And imagine if we could be more prescriptive for the clinician and say that, okay, these are the things that we're recommending, the top 3 or 4 items that you must do in this visit, because guess what? Last time the blood pressure reading was low. So it's really giving you the cue that may not be humanly possible for everyone to retain with, life happening and more patients coming in. And that's why it gives you those cues as well. And again, this is not 10 years. This is not even 1 year. This is next month. We're going to be rolling this out. And again, there's so many more things, which, happy to get into.
Well, one of the things that you're talking about is really making me think about, with my mom, she was in and out of the hospital 35 times in 5 years, the last 5 years that she was home before she went into the nursing home. And so almost every single time she came home, we got the referral for her to have home health. And it was starting all of that again. Now, fortunately for her, she ended up getting assigned the same nurse every time to come do that evaluation, but that all of that was still needed and still had to do, and the paperwork. And it sounds like some of that stuff could, at least the time could be lessened in the amount of repetitive stuff, especially when you're talking about somebody in and out of the hospital 2 times in 1 month, filling out the same thing. Instead of having to start from scratch every single time, there is this continuity that's just a lot easier when we have a tool that can store all of this information, analyze it, and then make suggestions, again, that is human evaluated and all of those things, but just shortening that workload of the time with each of those things happening. That as you were talking, I was just thinking about how that always took so much time. It's like, do we really need to do a whole complete reevaluation? You just evaluated her the last time she came home, which was 2 weeks ago.
Yeah, well, it's Medicare guideline that there needs to be, because see, if she was doing well and if there wasn't another assessment needed, then there wouldn't be any need to go to the hospital, like at least conventional wisdom, right? Because she went to the hospital, so then again that similar level of documentation is needed, and that's called the resumption of care. But all those questions minus the administrative questions need to be answered, and these questions are, okay, now what are your functional abilities? But you're right, a lot of that information needs to have the baseline that, okay, before this episode, this exacerbation that she had to be hospitalized, now what was it? Like, what were those values of her condition and everything? So yeah, if that's the baseline, and you're right, then it's going to be more accurate. And yes, it can go faster as well. But what I'm saying is that's only a small part of it, is what I realized. Like 10% of the visits, like I said, maybe these oasis visits, and the rest of the visits are regular skilled nursing visits that happen all the time, and they still need to be documented. You still need to come up with this 5,000 or 4,000 character summary of what you did and all that stuff. And some people can voice it, but then again, you have to correct it, and then again, you have to mark the right things, put it in the right place. I mean, so that's why what we're allowing is, go ahead and just record, let AI do the charting, let the human do the review, and then you have it in your EMR in Kinser, or whichever EMR that you're using, it's going to be in there. Going back to your earlier point, so like I said, prior to the visit, preparing the nurse, right, on what are some of the things based on the trajectory of the patient that would be best. Then during the visit as well, we're able to assist by giving that teaching material to the nurse. So we have, like just yesterday, launched this teachback.video. That's where you could go and have videos of, let's say, fall prevention, or understanding heart disease better, understanding, diabetes, or, different types of safety. So those videos are there, and that's our way to say thank you to the clinicians, and they don't have to retain as much, or, always carry like all these papers where they're going to read and train. And they could just open it up on the iPad and then show it to the patient and then talk about it. So that becomes sort of teaching, and that's recorded as well. So that can go directly into the note. So, I mean, that's another idea. Now, after the visit, of course, is the documentation. So that, of course, is what we started with, and that's going to continue to happen. But yeah, I mean, there can be many more innovations. However, one thing to keep in mind, AI is never going to replace what our amazing RNs do.
Something that I do, you talk about on your podcast all the time. It's part of what you do at Copper Digital, but this idea that the heart of caregiving is always going to be human. Technology's job is to protect that, not compete with it. And so I'm going to let you have the floor so that you can talk about what that means to you personally, to be building technology that is supposed to protect something as human as care.
Yeah. And, care is especially such a role and a job that it's very important for us to put it in a separate bucket. But even if you generalize and look at all the jobs that AI was supposed to take, is supposed to take, I mean, what I'm noticing is that if people who are doing those jobs, if they're open and understanding, then they can become that main subject matter expert to really do the best solution for using the AI. Like, I'll give you an example. We are also helping intake departments in home health agencies where the paperwork comes in and they have to make a decision. They have to do the insurance check. They have to do the PCP verification that the PCP is going to follow along in that case or not, and many other such things. Now, if we have that relationship with the intake team, they're willing to give us exactly what they do, and then we could automate that. But it's not like their job's going to go away. No, their job would evolve into something, which is reviewing stuff and exception handling, or making that phone call to the PCP, even though there can be voice AI agents, and we've definitely tried those as well in, a lot of our experimentation. But I think that personal connection that needs to be developed. So similarly, we bring it to caregiving. I mean, it is of the most importance that you are going out there and seeing the patient as a human for who they are, and just really helping them realize that you see them, you understand their pain, and you are going to do everything possible, for them to get better to the prior level of functioning and whatever their goals might be. If they want to lift their grandson or walk to the mailbox, they're able to do that. And, those things are just so important to be able to communicate and have that warmth and hold the hand. Is just super, super important. So I don't think, these humanoid robots are going to be able to do caregiving, and, not even in a decade, I don't think. And, I'd be happy to be proven wrong.
I feel very comforted by the idea that technology can support the human side of caregiving. And that's what I am trying to encourage and acknowledge and celebrate in the technology community, especially when it comes to healthcare. When families are navigating home health and they're just starting out, they're just getting the hang of it, or maybe they've been doing it for a while and they are curious about AI being used, as part of the care process for their loved one. Is there anything that they should ask or any sign that technology in their loved one's care is being used well versus in a way that might reduce the quality of care? What do you see there as agencies using it well versus agencies either not using it at all and that's causing problems, or agencies not using tech tools well?
No, that's a great question. And of course, that is important because our audience and the caregivers that are watching, they would like to know, okay, what can they do? Fine, there's all this great technology that's coming, and fine that clinicians are going to now not be so overloaded cognitively and be more available. So, yes, I think the way that I would advise anyone caring for their loved one is to first and foremost, like, make sure that the home health agency that they're hiring for their loved one, they actually care. They have a good track record. I mean, those fundamentals sort of never go away. I wouldn't want to discriminate against any of the home health agencies that may not have yet adopted AI because, hey, maybe they're being cautious. Maybe they haven't stumbled upon the right solution. Maybe they tried something and that didn't work, because this is a very long process. And over the next several years, we're going to see more and more adoption in different ways. So I wouldn't discriminate, number one. Number two, like I said, I think they just genuinely have to care. Now, if a company has, let's say, hey, we're going to be sending you these reading material or, this video, and we have this technology, and, we're going to be utilizing AI to do this and do that. I mean, that is definitely a positive. Then you're like, okay, great. That means you're already at the forefront of innovation and you're at that cusp. So, definitely you're going to be looking out for the new and the latest and greatest tools. Because one other thing that I want to mention to you is, like, one of the goals that home health agencies have is to reduce hospitalization. And that is the goal for Medicare as well. So that's why one thing with technology that we're rolling out is calls for wellness check on the patients in between the visits. And imagine being able to get a voice agent, which is very humanized and a clinician could call, but there's a shortage as well. And for certain acute cases, the clinician does call. And of course, the number's there. If something goes wrong, then you call back. And that's when clinicians are available. But we can serve more patients and check on more patients and prioritize which ones need care so we can prepone that visit. But AI agent calling and asking the patient, how are you doing today? Or asking the caregiver, how is the condition? And then based on any flags that they receive, they're able to give them that advice or have the main RN sort of call back to the caregiver, or, like I said, reschedule.
Yeah, well, I was just thinking about, like, 'cause I know it always happened to me. I know caregivers can probably relate. The home health person will say, "Do you have any other questions before I leave?" And you'll say no, and then 30 minutes later, there's a question, right? You think of something you should have said, or something happens. Like that's what would always happen with us, is like something weird would happen after the professional left our house, right? But I do want to just say, as an advocate for all the caregivers out there, please make sure that if I say I want to talk to a human, that can happen quickly. But I do see the value in having an agent just call and say, how's everything going? Do you have any questions? And then I can say, yes, actually, my mom spiked a fever. I need some help with that, or whatever. That would be helpful in a way to fill in that gap when, instead of having to call and leave a message and then somebody's got to get back to you when they can, which we've already established, the home health person is already pretty stretched for time. And so having to call somebody back is hard. So I love that idea. But like I said, my only request was that if we do ask for a human, we could get we could get one.
Yeah, right away.
We don't want to have to be yelling, representative, representative. Okay.
And no, by the way, it's very common, like including me, when I had a little bit of an accident in my Tesla, not a big one, just a parking lot. And I called Tesla, and then there's a voice agent. And I'm like, no, connect me with a real person. And it was 10 o'clock at night. And so, I mean, one would imagine that, oh, I should, be a little bit more kind to the AI agents, having created 17 different agents. But still, that is our nature. If we know that it's not a human on the other side, we're like, operator, human, or we answered like in just 2 words. I was also like, accident, insurance, instead of like, because we don't want to expend the effort of making beautiful sentences like we would for another fellow human, I guess.
We're trying to be efficient, just like the machines are, I guess. All right. All right. Well, as we wrap up today, if there's a family caregiver listening right now, someone who's navigating home health for their parent or a spouse, and they want to be more informed, they want to be an advocate, but they need to know how to do that for care for their loved one, where do you suggest they start?
Yeah, so I think the most important thing is to get that comfort from the home health agency that they're going to be caring and they actually care for the patient. And of course, then come other things like, do they have experience with wound care if, the patient has wounds, or do they have experience, or what's their rehospitalization rate? I think that's another question that can be asked. And then I think like the fundamentals are extremely important, but when we go to our information privacy, then those could be important questions as well, where it could be like, hey, are you guys HIPAA compliant? Or are you using our data to train certain things? I mean, there's nothing wrong, but at least there needs to be consent. Like similarly, when we have the ambient scribe, then there's a mandatory button, get the permission from caregiver and the patient, and then once you do, only then it starts recording. So, I mean, those types of checks and balances are important for us to be able to maintain the privacy of the patient. So I think those things are important to check. And of course, like, check their star ratings, which is a term in home health, which is like comparing you to the other agencies in that area. Yeah, just check the hospitalization rate. And I think, of course, they have to be available as well, because a lot of the home health agencies nowadays are not taking every single patient they get because they're just so short on clinicians. I mean, not as much as they were during the whole COVID crisis, but still it is improving slowly. But then there's just such a huge shortage in the industry. I think one more thing that I would say is, like, it may not be possible before you hire the home health agency, but once the home health agency is hired and then you get the clinician, like, what you want to make sure is you're getting a clinician that has good number of years of experience, because some of the nurses may have only worked in one area, and if your loved one requires, like, full head to toe care, or some very specific care, and then if the clinician's not aware, then you could always have like their supervisor, or not have an LVN, instead have an RN. So I think those kinds of considerations, like kind of being aware, keeping your eyes and ears open, and voicing your opinion, with the home health agencies. And most of them would listen and change because they're all trying to do good work.
Well, I know with my mom, her illness was very rare. So even and even an RN, usually they had heard about my mom's illness, but it's just not an illness that gets a ton of time during the clinical, work and stuff. And so as we would meet new people, and we would assess their understanding of my mom's main illness. And of course, she had lots of other things going on too. Usually whatever they were treating, like, wasn't necessarily part of her illness. It just was happening to her body. But one of the things that we would always do is just educate the people coming in as well. And so I think that that's, when we know we become experts in our loved one, it's okay to use our voice to educate the people that are caring for them as well. So, and then of course, to your point, all that goes in the all that goes in the chart, and then they have that knowledge base as well. So Arvind, thank you so much for you're building something amazing. And I love how you're really making sure that humans stay at the center of care. And in some cases, maybe we're putting humans back at the center of care, making that the most important thing, not the paperwork. And thank you for reminding us that technology at its best isn't about replacing what matters, it's about protecting it. And I know that AI can feel like a big word for those of you listening and watching. And I felt that way too. There would be a lot of times that I would struggle with how everything was changing so rapidly. But what I heard today, and what I hope you heard as well, is that the people building these tools, a lot of them are doing it because they believe in what they're doing. They want to get in and help people within the system. In this case, Arvind's case, nurses who walk through our doors so that they can take care of our loved ones. If this conversation gave you something, a question to ask your home health agency, a little more piece about what's coming, or just a new way of thinking about care for your loved one, Please share it with other caregivers in your life. Arvind, again, thank you so much for coming. Is there anything else you want to say before we wrap up today?
No, this has been wonderful. Thank you for asking some wonderful questions. I feel like I've communicated what I wanted to, and I'm excited to engage with your audience as well in the coming weeks and months.
Well, I'm going to put everything, Copper Digital's website, I'm going to put the podcast that you do, all of that into the description and the show notes of this episode so that people can connect with Copper Digital, learn more about what you're doing. You have some great interviews on your podcast all of the time. And I'm not just saying that because I was one of them, but it shows up on my YouTube all the time. And I always enjoy the conversations you have. You're having a lot of important ones. So I appreciate that. If you haven't already, please subscribe so that you don't miss an episode, and you can find out more about Copper Digital, all of the stuff that we talked about in the show notes. And you can also check out the resources at JeanetteYates.com. And until next time, feel good, not guilty.